friends, we are going to discuss today on pancreas. So pancreas is one small chapter but full of high-yield points, and it is the most favorite topic for national board examiners. So let us start with the basics of pancreas. Let me start with some basics of pancreas like anatomy and embryology. So let me start with embryology of pancreas. So this is the duodenum, and embryologically the pancreas is derived from two ducts. Is derived from this dorsal bud and from this ventral bud. These are the two buds which is going to form pancreas now. So usually the ventral bud rotates and comes here by around 6th week. By around 6th week of intrauterine life, the ventral bud will rotate and will fuse with the dorsal bud and form the pucca pancreas anatomy as shown here. So the pucca anatomy will be formed in 6th week. But what are the problems which can happen in this embryological rotation? If the ventral bud does not rotate, if it remains in the same place, or if there is a malrotation, you can see a disease developing known as annular pancreas. Annular pancreas is failure of rotation of ventral bud. Please don't forget, annular pancreas is failure of rotation of ventral bud. By chance, if they rotate, after rotating, the dorsal bud and ventral bud are remaining separately like this and they are not fusing with each other. If they are not fusing with each other, that is known as pancreas divisum. Okay, these are the two important anomalies seen in pancreas, annular pancreas and pancreas divisum. So annular pancreas and pancreas divisum, let us discuss what happens in those cases. For example, if this is a duodenum, what happens in annular pancreas is the ventral bud and dorsal bud is encircling the pancreas like a ring. They are encircling the pancreas, and they present with the clinical feature of gastric outlet obstruction. That is a clinical feature of annular pancreas. They present to you with the gastric outlet obstruction. And this anomaly is also associated with Down syndrome. Please don't forget, it is associated with Down syndrome. Very important point, Down syndrome, and it is also associated with intestinal atresia, like duodenal atresia may be associated with this annular pancreas. So the investigation of choice for annular pancreas is by means of CT scan. We can confirm there is a compression seen in the duodenum, and if you want more further clarity, we can go with ERCP also. ERCP will show you the absence of ventral bud. Okay, so ERCP is also one of the important investigations. And what is the treatment of this annular pancreas? And this is a long-run controversy. The treatment, there are two types of treatment. We can either do duodeno-duodenostomy or we can do duodeno-jejunostomy. And Bailey says duodeno-duodenostomy and Sabiston says duodeno-jejunostomy. So again, Bailey is not correct in this place. The correct answer is Sabiston only, but for national board exams, you must follow Bailey law. So for national board exams like NEET PG, you have to follow Bailey law. So the answer is duodeno-duodenostomy. The duodenum will be anastomosed with duodenum, and this is known as duodeno-duodenostomy, and we don't resect the annular pancreas. We don't go and resect it. So that resection is not done. It is only duodeno-duodenostomy is done. So resection is done very rare cases. Very rare cases we do resection. The treatment is duodeno-duodenostomy. Please don't forget this point. Okay, it is associated with Down syndrome, and the treatment of choice according to Bailey law is duodeno-duodenostomy. So to understand pancreas divisum, you should understand the normal duct anatomy of pancreas. Then only you can understand the pancreas divisum. So now I am drawing the normal pancreas. This is head of pancreas. So please remember, this is head of pancreas. This is uncinate process. This is neck of pancreas. This is body. This is tail. So this is the neck of pancreas. Into this neck, which vein enters? Can you tell me which vein enters into this neck? So what is the vein which is entering the neck? Under the neck of pancreas, what vein enters? It is superior mesenteric vein. It fuses with another vein, that is splenic vein. And as it comes out as portal vein. Please don't forget, it comes out as portal vein. So superior mesenteric vein joins with splenic vein and comes out as portal vein. There is a tunnel below the neck of pancreas. What is the name of this tunnel? So this tunnel is a neat super specialty question known as tunnel of love. Why it is known as tunnel of love? Because in those days, pancreatic surgeons, when there is a tumor in the head of pancreas, they love that the tunnel is not infiltrated. In those days, we do Whipple's operation only when the tunnel is not infiltrated. This concept is no more. Even with infiltration of tunnel of love, now surgery is done. So this concept of tunnel of love is no more there. But for MCQ, you can get where is tunnel of love. Tunnel of love is seen in the neck of pancreas, into which superior mesenteric vein enters and come out as portal vein. Please remember this tunnel of love. And at this point, you should know the duct. So this duct which I am drawing is, what is the name of this duct? This is the major duct of pancreas. What is the name of this duct? This duct which I am drawing, which drains from the tail, body, and uncinate process and part of head, is known as Wirsung, duct of Wirsung. That is a major duct of pancreas known as duct of Wirsung. And there is a minor duct which is draining only small part of head, that is known as Santorini. So now there are two ducts. Please remember, there are two ducts. So the major duct of Wirsung is the one which is draining major part of pancreas, and this is joined by common bile duct, and we have discussed this concept in previous chapter. So this is joined by bile duct and they enter into the ampulla. So this is, you all know very well, they enter into the ampulla, and that is guarded by sphincter of OD, all these things you know. And it is guarded by sphincter of OD, all these things you know. And the minor duct is running like this. It is minor duct of Santorini. So now you should understand the two buds which I already discussed. This is dorsal bud, this is ventral bud. You can see the distal part of dorsal bud duct. This is distal part of dorsal bud duct, and the full ventral bud duct will fuse to form the major duct of Wirsung. So how is the major duct of Wirsung formed? By the distal part of dorsal bud and full ventral bud forms major duct of Wirsung. The distal, this is a embryology question from PG Chandigarh exam. So please don't forget, the distal part of dorsal bud and the full ventral bud forms the major duct of Wirsung. And the minor duct of Santorini is formed only by the proximal part of dorsal bud. The minor duct of Santorini is only formed by proximal part of dorsal bud. Please don't forget this point. This is a high yield point for your exam. It's formed by proximal part of dorsal bud. High yield MCQ for your exams. So please don't forget, the major duct of Wirsung is formed by entire ventral bud duct and distal part of dorsal bud. The proximal part of dorsal bud will form only duct of Santorini. Only formed by duct of Santorini, the minor duct of Santorini. So Wirsung is a major duct. Wirsung is a famous anatomist. He found this Wirsung duct by dissecting a person, a murderer. He dissected this in his cadaver and found this. And in the fact, the bad scenario is the Wirsung himself was murdered after 1 year of finding this duct. So Wirsung duct has a history which is given in Bailey law. This is a history from Bailey law. So his Bailey law, when you read, there is full of funny history given at the underneath. When you see, there will be small paragraphs written at the underneath of each chapter. So that Wirsung was murdered after 1 year of finding out this Wirsung duct in a murder. Okay, so that's one of the dissection done by him. Wirsung duct. Wirsung duct is a major duct, and if these two ducts do not fuse, and if they remain like this, if these two ducts do not fuse, and if they remain like this, and like this, so what will happen? The bile duct joins with this duct, and it opens in the ampulla, and this is the minor duct opening here. Minor duct opening is very small opening, and it is now draining major part of acini of pancreas. Major part of pancreas is drained by minor duct. So what will be the clinical feature of these cases? Pancreas divisum. The clinical feature is recurrent acute pancreatitis. Because the small duct is draining such a major part of pancreas, they get recurrent acute pancreatitis. And investigation of choice is ERCP. We can also diagnose by MRCP, but best answer is ERCP. Best investigation of choice is ERCP, but in MRCP also can diagnose recurrent acute pancreatitis caused by pancreatitism. When young boys or young girls come to us, our clinic at around 12 years, 15 years, 16 years, we always send them for MRCP or ERCP to look for pancreatitism, and many times we find out pancreatitism in those cases. And treatment is minor duct. The minor duct will be undergoing sphincterotomy. Please remember, minor duct sphincterotomy will be done. So the treatment is minor duct sphincterotomy. Please don't forget. So the clinical feature is recurrent acute pancreatitis, and investigation of choices ERCP or MRCP, and minor duct sphincterotomy is done for those cases. Minor duct sphincterotomy is done for those cases. So these are the important points from the embryology. And one other embryology point I want to tell you is ectopic pancreas. Ectopic pancreas is another important anomaly you should not forget. Ectopic pancreas, and ectopic pancreas is most commonly seen in duodenum according to Blumgart. It is according to Blumgart. It is most commonly seen in duodenum followed by stomach. It can also be seen in Meckel's diverticulum. It can also be seen in Meckel's diverticulum. So please don't forget, ectopic pancreas most common site is duodenum according to Blumgart. Okay, please, this point is from Blumgart, because in Bailey and Sebastian they mention the order as stomach, duodenum like that, but correct answer is duodenum is the most common site of ectopic pancreas. Okay, so when you come to pancreas chapter, it's a very small chapter. We deal with only two topics. What are the topics to be discussed in pancreas are only two as a surgeon. One is acute and chronic pancreatitis. Another is tumors in pancreas. That's all. In pancreas, the entire chapter is acute and chronic pancreatitis and tumors. So now let me start my discussion on one of the most high yield topic for your exams, that is acute pancreatitis. Okay, acute pancreatitis. Let us start our discussion. Acute pancreatitis, let us start our discussion. So one of the high yield topic for your exams, you must not make any mistake in this topic of acute pancreatitis in your exams. Acute pancreatitis, what are the etiological factors? What are the etiological factors? The mnemonic for etiological factor is get smashed is the mnemonic. So the etiological factors, I used to remember the mnemonic get smashed. Get smashed. G for gallstones is the most common etiology. Gallstone is the most common etiology. The second common etiology is ethanol. And in children, the most common etiology is trauma. Please don't forget, in children, most common in children is trauma. So trauma to the pancreas, the most common etiology is gallstones, ethanol, trauma. And coming to S for scorpion bite, M for mumps, A for autoimmune, S for steroids, E for ERCP, and D for some drugs. What are the drugs? The drugs like diuretics, like thiazide diuretics, valproate, many chemotherapy drugs, they all can cause pancreatitis. Why I have not discussed H? Because H is a high yield topic for exam. So what all come in H? Hypercalcemia, hyperparathyroidism, hypertriglyceridemia, hypercalcemia, hyperparathyroidism, hypertriglyceridemia, calcium, parathyroid, all these all come under H. And apart from this, there are some infections like Coxsackie infection can cause acute pancreatitis. Okay, acute pancreatitis can be caused by Coxsackie. So these are the various causes of acute pancreatitis. And what are the clinical features? The patients of acute pancreatitis will come to hospital. So please remember, acute pancreatitis is an essay question for final years. So final years, please concentrate. So the clinical feature is the patient comes to you with a pain in the epigastric region radiating to the back. Pain in the epigastric region radiating to the back. Therefore, the patient will be sitting like this in a leaning forward position. Pain radiating to epigastric to back. So the patient therefore will be sitting in a Muslim prayer sign known as Mohammedan prayer sign. Pain is the most common symptom of acute pancreatitis. They may have vomiting. Due to edema around the pancreas, they may have vomiting, pain, vomiting. And if the patient is having hemorrhagic pancreatitis, what are all the signs you can elicit on examining the abdomen? Hemorrhagic pancreatitis, what are the signs seen? Not in a normal pancreas. If it is a hemorrhagic pancreatitis, the signs seen in the abdomen, apart from routine guarding of the abdomen, they will also have the following signs. Pigmentation around the umbilicus, pigmentation around the loin, pigmentation around the inguinal region. What are these known as? Pigmentation around the umbilicus is known as Cullen sign. Around the loin means you turn. So remember Gray Turner sign. Gray Turner sign is in the loin. Inguinal region is Fox sign. So the signs seen in acute pancreatitis are Cullen sign, Gray Turner sign, Fox sign are the clinically seen signs. Clinical signs seen in acute pancreatitis. So naturally, the important differential diagnosis in an acute pancreatitis patient admitted in your hospital is perforation. So perforation peritonitis. This case mimics like a perforation peritonitis. So what will you do immediately for a perforation peritonitis patients? Can you tell me? So whenever an acute pancreatitis patient, you will immediately send them for an X-ray abdomen erect. This is routinely done because we have to rule out perforation. Because if it is a perforation, we have to operate immediately. Therefore, we send the patient for X-ray abdomen erect. What are the signs seen in acute pancreatitis? So last year neat question. Gasless abdomen, ground glass appearance and gasless abdomen are due to fluid collected inside the abdomen. And there may be sentinel loop. What is sentinel loop? A bowel loop of small intestine not functioning. That is sentinel loop. You can also see renal halo sign, which is also seen in perforation, but renal halo sign means air around the retroperitoneal region due to infective pancreatic necrosis. There may be renal halo sign, and 100 times asked MCQ, all of you should not forget this. That is colon cutoff sign. I will show you the image. In the colon, there will be a part of colon missing. That is known as colon cutoff sign. So in an X-ray abdomen erect, what are the signs seen are gasless abdomen, ground glass appearance, sentinel loop, renal halo sign, and colon cutoff sign. In this, colon cutoff sign is asked in the exam. Gasless abdomen is asked in the exam. So now you are getting a doubt. It can be a acute pancreatitis. Now you send the patient for certain investigations. So the investigations done are, please remember, the investigations done are, most commonly done investigation is serum amylase. Serum amylase, if it is more than 4 times increased of normal value, it is diagnostic of acute pancreatitis. If serum amylase is 4 times increased than case of normal value, it is known as acute pancreatitis. But it is not specific. It is most commonly done, but it is not specific because it is also elevated in perforation. It is also elevated in perforation cases. So already we are having a confusion whether it is a perforation. So when you do this, it will again make confusion whether it is perforation or pancreatitis. It can also be elevated in diverticulitis. It can be elevated in intestinal obstruction. It can be elevated in mesenteric ischemia. So in otherwise, if you want to remember simple method, any acute abdomen will have amylase elevated. Any acute abdomen will have amylase elevated. But anyhow, this is the most commonly done and the first done investigation amylase. The major drawback of this is it will become normal after 3 days. After 3 days of attack, usually it becomes normal. That is a major issue with this. It will become normal after 3 days of attack. So therefore, what is most sensitive? Most sensitive investigation. So we can clearly say amylase is not most sensitive. Many times it will become normal after 3 days, and it will also become normal after recurrent attacks. After recurrent acute pancreatitis, it will become normal. Therefore, the most sensitive test is serum lipase, is the most sensitive test. And substance is most sensitive and also specific is serum lipase. But I will tell you this is not specific. Why? Because lipase is also elevated in parotitis. So therefore, specific means what? It should be elevated only in that condition. So to super specialty level, the most specific answer is serum trypsinogen. Serum trypsinogen is elevated only in acute pancreatitis, though not commonly done. Serum trypsinogen is the most specific investigation. So please don't forget, most sensitive is serum lipase, most specific is serum trypsinogen. Please don't forget these points. So these are the investigation related questions. And always we measure C reactive protein, and if it is more than 150, it is a case of severe acute pancreatitis. C reactive protein more than 150 is a case of severity. It predicts the severity. The case is having severe acute pancreatitis. Please don't forget this. Okay. So these are the points you should not forget in acute pancreatitis. What is the investigation of choice? Radiological investigation of choice. I'm asking you the radiological investigation of choice for acute pancreatitis is CECT abdomen. We have to do CECT abdomen with oral and IV contrast. Please don't forget we have to do oral and IV contrast. CT abdomen is the investigation of choice that will show you a scoring known as Baltasar. Baltasar criteria is an old name, and this is now changed to CT severity index. I'm going to discuss it separately, don't worry. So that is known as CT severity index or Baltasar score. So old name is Baltasar score, latest name is CT severity index, and CT abdomen is usually advised after 72 hours only. Before 72 hours, the necrosal will not be seen. So it should be done only after 72 hours. CT severity index is the investigation of choice is CT abdomen. Okay, CT abdomen. So now coming to the scoring systems. Very important in this topic is about the scoring systems. So scoring system is very important in acute pancreatitis. So if you ask me what is one of the boring to treat as a surgeon, sir, what do you feel will be most worst to treat as a surgeon, sir, means I will immediately tell acute pancreatitis. Usually I will never treat acute pancreatitis in my hospital because it is like managing a cobra snake. So if the cobra snake either can bite you or it can bite the patient. So either the patient may die or you may die because of the patient death. So very dangerous to manage acute pancreatitis. Usually acute pancreatitis patients should be better managed in a multi-speciality setup. So usually I don't manage it as a single person. In my hospital I will use to refer the patient to a multi-specialty hospital. Okay, so the scoring systems used because since acute pancreatitis, you have to know whether it is mild or moderate or severe. There are so many scoring systems introduced. So therefore, you must know at least some scoring systems. You must know the names. You should not forget the names. And the names are Ranson score. Is very old score from our days of PG preparation. We will prepare Ranson score, and it is still asked in exams because it is there in Bailey and Law. Ranson score, Apache 2 score. You'll be reading in medicine about Apache 2 score, which is containing 12 factors. Will be taken into account. There are 12 factors taken into account. Glasgow score, which is a modified Glasgow score, which is not like a head injury Glasgow. This is a different score. Modified Glasgow score. Bedside index of severe acute pancreatitis. This is known as BISAP. Bedside index of severity of acute pancreatitis score, known as BISAP score. And already I told you, the best among various scoring systems is CT severity index score is the best scoring system. To know whether it is mild or severe pancreatitis, CT severity index is the best scoring system. And recently there is a score introduced known as revised Atlanta score. The original Atlanta was in 1990s. Now the revised Atlanta score is being used by surgical gastroenterologists and medical gastroenterology people. So revised Atlanta score is one of the another scoring system which we are commonly using. So in this, you must know the following scoring systems in detail for your exam. One is Ranson score, another is CT severity index score, and another is revised Atlanta score. So though all scores are important, it is very difficult to remember and memorize every score. So I used to remember only certain scores. Let me tell you whatever I used to remember. So BISAP score is easy to remember because the BISAP itself is a mnemonic. That is why I am telling BISAP. BISAP itself has a mnemonic given by the BISAP scoring itself. B stands for blood urea nitrogen. BISAP. B for blood urea nitrogen. I for impaired mental status. Okay, mental status. S for systemic inflammatory response syndrome. A for age above 60 years, and P for pleural effusion. So BISAP score is very easy to remember based on the mnemonic. Blood urea nitrogen, I for impaired mental status, S for SIRS, and A for age above 60 years, and P for pleural effusion. So this scoring can be done from 24 hours onwards. After 24 hours, we can use this scoring system to say what is happening to the patient. So otherwise, this scoring is not being asked many times in the exam. Just know the name and what are the factors in BISAP scoring. I want you to memorize the important score, that is Ranson score. Definite question from Bailey and Law, and it is an MCQ for us from our days of PG preparation in 2003 onwards. We used to prepare this, and since it is very difficult to remember, we used to keep a mnemonic in those days. So the scoring is done at admission. And the major drawback of this scoring is nobody sees this patient up to 48 hours. The second scoring is done only at 48 hours. Many patients became bad in this 48 hours. That is the major drawback of this score. So Ranson score is done at admission and at 48 hours. So at admission, what are all seen? The mnemonic is Lagao. Remember the mnemonic as Lagao. And at 48 hours, the mnemonic is Buchau. So Lagao, Buchau is the mnemonic. Very easy to remember. You will never forget this for your exams. Lagao means LDH. A for aspartate transaminase. G for glucose. A for another age. W for WBC count. So Lagao, LDH, aspartate transaminase, glucose, age, WBC count. Buchau, base deficit. Same again, urea nitrogen, calcium, hematocrit, oxygen, PaO2, water fluid loss or water fluid sequestration. Water fluid sequestration, that is being lost as a third space loss. Water fluid sequestration. These are the points at admission. Lagao at 48 hours. Buchau. So now if you want, you have to remember some of the values. May be asked for institute exams, may not be asked in national board exam, but the institute exams can ask this. LDH more than 350 units per liter. Aspartate. LDH is more than 350 units per liter, aspartate transaminase more than 250 units, blood glucose more than 200 or more than 1.1 millimoles per liter. Age is more than 55 years and WBC count more than 16,000. More than 16,000. So please remember, this question has been asked in AIMS. LDH value more than 350 units per liter is asked in AIMS. So Lagaw means LDH, aspartate transaminase, glucose, WBC count. So please remember, Lagaw, LDH more than 350, aspartate more than 250 units per liter. So glucose, remember, more than 200, age above 55 years, WBC count above 16,000. And base deficit more than 4. The base deficit value is more than 4 millimoles per liter. And urea nitrogen more than 5 milligrams per deciliter. Urea nitrogen more than 5 milligrams per deciliter. Serum calcium here, please remember, it is less than 2 millimoles per liter. What happens here? In serum calcium, what is happening here? You have to know an interesting point. All factors I am telling are elevated, but calcium is decreasing. Please remember, calcium is decreased. Calcium is decreased. And hematocrit fall. There is a hematocrit fall more than 10% fall. Hematocrit is one of the important values. There is a hematocrit fall more than 10% fall. Hematocrit fall. PaO2 less than 60 millimeters mercury and water fluid sequestration more than 6 liters. And in this, the two blue highlighted things are decreased. All other things are increased. Okay. So hematocrit, I'm not measuring the hematocrit, I'm measuring the hematocrit fall. Okay, hematocrit fall is more than 10%. So these values are taken directly from Bailey and Lowe 27th edition. You must remember these values. So serum calcium is decreasing, partial pressure of oxygen is decreasing. All other things will get elevated. So in Ranson score, what are the factors which decrease also can be asked? Calcium and oxygen will be decreased. LDH increase, aspartate transaminase increase, glucose increase, age increase, WBC count, base deficit more than 4 millimoles, urea nitrogen more than 5, and water fluid loss more than 6. You remember, base deficit 4, urea nitrogen 5, water fluid loss 6. Remember like that. So 4, 5, 6. Okay. So when the scoring is more than 3, more than or equal to 3 in admission, it is severe. If it is more than or equal to 3 at 48 hours, it is severe. So the scoring is when it is more than or equal to 3, it is known as severe acute pancreatitis. So come back to the previous table column. So Ranson score is said to be severe acute pancreatitis when the score is more than or equal to 3. When the scoring is more than or equal to 3, it is severe. Apache 2 scoring when it is having more than or equal to 8 factors, it is severe. When there are more than or equal to 8 factors, it is severe. Glasgow score is said to be severe when there are more than or 3 positive among the 8 factors. Okay. So now coming to the best among all the scoring systems, which is used as CT severity index, which is an old name. Old name is known as Baltasar. That old name of Baltasar is now removed and we have a new name, CT severity index scoring system. In this, we will look for pancreas inflammation. What are the things you will look in this are? We will look for pancreas inflammation and we will look for pancreas necrosis. Inflammation and necrosis will be looked upon in this. So in inflammation, pancreas inflammation, the values to be given are normal pancreas is given 0 value. Normal pancreas is 0 value. Focal enlargement or diffuse enlargement of only enlargement of pancreas like this. The pancreas is enlarged, that's all. It is given 1 point. There is enlargement of pancreas. If there is an intrinsic derangement inside the pancreas, there is inflammatory changes. Apart from focal or diffuse inflammation, there is intrinsic changes. So there is intrinsic changes. Intrinsic changes are seen. It is known as 2 points. So remember, just pancreas is enlarged. There are some intrinsic changes, 2 points. And coming to the fluid collection around the pancreas. If there is single fluid collection, it is given 3 points. If there is multiple fluid collection, it is given 4 points. That's all. Simple scoring system. So pancreas, first of all, you see if it is a focal or diffuse enlargement, 1 point. Intrinsic changes, 2 points. Single fluid collection, 3 points. More than one collection, it is 4 points. And coming to necrosis, if this is a pancreas, if less than 30% of the pancreas lost its blood supply, less than 30% necrosis, or it can be 30 to 50% necrosis, or it is more than 50%. So you give 2, 4, 6. The values given are 2, 4, 6. Less than 30% necrosis, 2 point. 30 to 50% necrosis, 4 point. And more than 50% necrosis is 6 points. So the total scoring is 10. So please remember, the total scoring is 10. So when will you say the scoring is severe acute pancreatitis? When the score is 7 to 10, it is known as severe acute pancreatitis. It is known as severe acute pancreatitis, which has a mortality of around 17% mortality. So this is very well used scoring system known as CT severity index score. So it is very simple. I will show you the CT scan. Just by seeing the CT scan, the radiologist will give the scoring. So the radiologist scoring, when the scoring is more than 7 up to 10, more than or equal to 7 up to 10, it is known as severe acute pancreatitis. The patient is going to die 17% of the time. So the point you should remember here is we should look for inflammation and necrosis. We should look for inflammation and necrosis. So please don't forget this scoring system, and this is the best used scoring system by surgeons. By surgeons, the most commonly used scoring system is the CT severity index scoring system. Then what we gastroenterologists are using? We are using another scoring system, which is revised Atlanta score, revised Atlanta classification or score. Revised Atlanta classification or scoring system is what we surgeons are using. Please don't forget this scoring system. This scoring system is going to tell about organ failure. This will discuss about organ failure. This will discuss about local complications seen around the pancreas. And this will also discuss about some of the systemic complications around the pancreas. Systemic complications also will be discussed in this Atlanta classification. We have to check for all these things. So what are the organ failures you will look means? You should look for shock. Shock is defined by a systolic blood pressure less than 90. So shock is defined by a systolic blood pressure 90. Acute respiratory distress syndrome, ERDS or pulmonary insufficiency, is discussed by PaO2 less than 16 millimeters mercury. So we have to look for ERDS, the partial pressure of oxygen will be less than 60. Or look for acute renal failure in which serum creatinine will be more than 2 milligrams per deciliter. So serum creatinine will be 2 milligrams per deciliter. Another thing you will look is GI bleeding, more than 500 ml per day. So what are all considered as organ failure? Organ failure of heart is BP less than 90, lungs is PaO2 less than 60, acute renal failure, serum creatinine more than 2 milligrams per deciliter, and GI bleed is more than 500 ml per day. And what are the local complications that will be coming under Atlanta classification are? They are pseudocyst, abscess. We'll be discussing about complications later. Just remember the names. Pseudocyst, abscess, and necrosis are coming under local complications. Please don't forget they will come under local complications. Pseudocyst, necrosis, abscess. And what are the systemic complications? The systemic complications, though not much important. Just remember DIC. DIC is one of the systemic complications we will measure. And metabolic disturbances like metabolic acidosis, all those things. And fibrinogen level is decreasing. So these are all some things you will look for systemic complications. Now how will you make the classification based on these things? You have to see for all these things and you make a RAC classification, Revised Atlanta classification of acute pancreatitis. Is a very simple classification. You can easily tell. You can, as a, not only this is needed by, done by surgical gastroenterology, even an MBBS graduate can easily make this grading: mild, moderate, and severe. See how simple it is going to be. So the classification of acute pancreatitis into mild, moderate, severe is going to be very simple. There is no local complication. So please remember, no local complication, no organ failure. It is known as mild. Only there is amylase elevation. That's all. Mild pancreatitis, no local complication, no organ failure. Moderate, there is organ failure present, but it is a transient failure. Organ failure is transient. What do you mean by transient? It resolves in 48 hours. On resuscitation, it resolves in less than 48 hours is known as moderate acute pancreatitis. Resolves in 48 hours is known as moderate acute pancreatitis, and they may be associated with local or systemic complications. They may be associated with local or systemic complications, but there is no organ failure. So organ failure which is present less than 48 hours, and there may be local or systemic complication, but no persistent organ failure. Please remember, but no persistent organ failure. So that is moderate. So the patient becomes normal in 48 hours. When you go and see 48 hours later, the patient is recovering. So it is moderate. Severe is a dangerous case. Again, I will tell you, persistence of organ failure more than 48 hours with local or systemic complication. So systemic complication and local complication are present along with organ failure for more than 48 hours, known as persistent. So persistent organ failure above 48 hours is known as severe acute pancreatitis. So in 48 hours itself, in a pancreatitis patient, you can say whether he is a moderate or severe case. Please remember, in 48 hours you can say whether he is a moderate or severe case. Okay. So this is revised Atlanta classification of acute pancreatitis. Now just let us revise the scoring systems. Just I will give you a fast review. Please remember the scoring systems we discussed. So the scoring systems are Ranson's, Lagau, Buchow. Please don't forget the mnemonic is Lagau, Buchow. It is done at 0 hours and 48 hours. When it is more than or equal to 3, it is severe acute pancreatitis. Apache 2 has more than or equal to 8. Glasgow score is there, which is more than or equal to 3, and bedside index of severe acute pancreatitis is another score, and CT severity index more than 7 to 10, up to 7 to 10 is severe. So revised Atlanta classification is a easy scoring, mild, moderate, severe. So there are some other scoring systems which are not commonly used, or for acute pancreatitis not commonly used, are modified Marshall score. Just I'm telling you the names. Modified Marshall score. We can also use the SOFA score, which we discussed in septic shock. SOFA score, sequential organ failure assessment score, is also used, and we use simple method CRP more than or equal to 150 is also another method of assessing the severity of acute pancreatitis. To assess the severity of acute pancreatitis, these are the various scoring systems you should never forget for your exams. Okay, forget the scoring systems which we discussed so far. So Ranson's, CT severity index, revised Atlanta are the 3 important scoring systems which we surgical gastroenterologists follow. Okay, please don't forget revised Atlanta scoring system. So now coming to the very important topic in pancreas, acute pancreatitis, that is complications of acute pancreatitis. So please remember, there is an insult on the pancreas, either by gallstones or by alcohol. The pancreas is insulted. So the trypsinogen is triggered. So the trypsinogen is released. So you know the function of trypsinogen from physiology. It will activate all the enzymes from the pancreas, like amylase, lipase, trypsin, chymotrypsin. Everything is now released into the circulation. So they don't know whom to digest. Amylase, lipase, chymotrypsin, trypsin, all those things, elastase, everything is released into the circulation. They don't know whom to digest. So they go back and digest the pancreas itself and result in further damage, further release of enzymes. This is known as autodigestion. The basic concept of acute pancreatitis is autodigestion. This is what happening in acute pancreatitis, known as autodigestion. So what happens in autodigestion? The autodigestion results in the following local complications. Local complications around the pancreas. You can write in your essay question like local complications of acute pancreatitis and systemic complications of acute pancreatitis. Systemic complications all are due to the release of interleukin 1, interleukin 6, TNF alpha. All these inflammatory mediators are released into the circulation. Inflammatory mediators you're reading in pathology, interleukin 1, 6, alpha, TNF, everything will be released into circulation, and they cause the systemic complications that are already discussed in RAC. They are shock, they are acute renal failure, acute respiratory distress syndrome, ARDS, acute renal failure, shock, GI bleed, and there comes the most common cause of death, that is MODS, multi-organ dysfunction syndrome, is the most common cause of death. Most common cause of death in acute pancreatitis is multi-organ dysfunction syndrome. So one of the systemic complications which follows shock, acute renal failure, ARDS, and GI bleed is multi-organ dysfunction syndrome. That is the most common cause of death in acute pancreatitis. Especially this is most common cause of death in early period. Most common cause of death in early period of acute pancreatitis. In the early period, within 24 to 48 hours, the common cause of death is MODS. So now coming to local complication. So local complication can be happening less than 4 weeks. What are the local complications? And after 4 weeks, what are the local complications? So please remember, if this is an inflamed pancreas, within 4 weeks we can see here and there fluid collection like this. Fluid collections like this. This is known as acute pancreatic fluid collection. Collection of fluid around the pancreas within 4 weeks is known as acute pancreatic fluid collection. And this acute pancreatic fluid collection can form a well-defined wall without epithelium after 4 weeks. Can form a well-defined wall without epithelium. That is known as pseudocyst. So please remember, pseudocyst is formed after 4 weeks. It is formed after 4 weeks. So acute pancreatic fluid collection or pseudocyst. Or there can be pancreas can cause acute necrotic fluid collection. Okay, necrotic collection, necrotic fluid collection. So not only there is fluid, there is also necrotic material seen. So that necrotic material can form a well-defined wall. Along with the necrosis in the pancreas, the necrotic material can form a well-defined wall. That is known as what? Looking like a pseudocyst, but it is not pseudocyst, because in pseudocyst there is only fluid. But this guy will not only have fluid, it will also have necrotic material, known as walled-off pancreatic necrosis. Walled-off pancreatic necrosis. That is known as walled-off pancreatic necrosis. The collection is known as walled-off pancreatic necrosis. So less than 4 weeks is known as acute pancreatic fluid collection and acute necrotic fluid collection. More than 4 weeks, the same cases will develop into pseudocyst or walled-off pancreatic necrosis. And the most common complication of pseudocyst is what? The most common complication of pseudocyst or with the necrosis is going to be infection. If there is an infection overlying the pseudocyst or pancreatic necrosis, it is known as pancreatic abscess. Please remember, it is going to be known as pancreatic abscess, and this is the most common cause of death due to local complication. Most common local complication causing death. Most common local complication causing death is this infection, most common local complication causing death, and this is the most common cause of late death. Most common cause of late death in acute pancreatitis is due to pancreatic infection or abscess. Okay, so please don't forget that is another complication. So I'm telling you various complications. You can see from the picture the acute pancreatic fluid collection, necrotic collection, walled off pancreatic necrosis, pseudocyst, pancreatic abscess. What are the other complications? There is a list of complications. Pancreatic ascites. Please remember there is other complication known as pancreatic ascites. Pancreatic ascites. Then pancreatico-pleural fistula. Pancreatico-pleural fistula. Pleural effusion. Pleural effusion. Then splenic vein thrombosis. See, interesting complications. Splenic vein can get thrombosed. Splenic artery can get aneurysm. This is because of the elastase enzyme which damages the vessel. Elastase enzyme which is damaging the vessel results in splenic artery aneurysm. It is a false aneurysm. Splenic vein thrombosis, splenic artery aneurysm, colonic gangrene. The colon can get gangrene. It's another complication. Colonic gangrene or perforation. So colonic gangrene or perforation is another local complication. So these are all various local complications of acute pancreatitis. I'm going to discuss some of the salient local complications. One of the most commonly asked MCQ is pseudocyst. Pseudocyst pancreas can follow either acute pancreatitis or follow chronic pancreatitis. It can follow both acute or chronic pancreatitis. So pseudocyst is most commonly seen where? It is most commonly seen behind the stomach. So please remember, this is stomach, and posterior to the stomach we have the pancreas. So this is exactly seen posterior to the stomach, between the stomach and pancreas like this. So the most common site is lesser sac. Most common site of pseudocyst is lesser sac, but it can happen anywhere. Please remember, it can happen anywhere in the abdominal cavity. It can happen in the iliac fossa, it can happen in the lumbar region. Anywhere it can happen, but the most common site is lesser sac, and in the lesser sac it is most common in body and tail of pancreas. Near the body and tail of pancreas it is more common. It is not near the head. It is more common near the body and tail of pancreas. That is a well-defined fluid collection, cystic lesion with a well-defined wall with no epithelium. The wall is having no epithelium. Please remember, the epithelium is not there. So there is a classification of pseudocyst known as DEGDO classification. The classification of pseudocyst is DEGDO classification of pseudocyst. There are three types. There are three types of pseudocyst. Please don't forget. Type 1, type 2, type 3. Type 1 follows acute pancreatitis. Type 2 follows acute on chronic pancreatitis. Type 3 follows chronic pancreatitis. Simple classification. So following an acute pancreatitis is DEGDO 1, 2 is acute on chronic pancreatitis, 3 is following a chronic pancreatitis. In type 1, the duct is normal. Please remember, the duct is normal. And there is a cyst. The duct is normal. Please remember, duct is normal in type 1. In type 3, there is a communication from the duct to the cyst like this. In type 3, there is a communication from the duct to the cyst, and there are strictures also. So duct is having, in type 3, easy to remember, communication is present. Stricture is also present. Both are present in type 3. In type 2, the duct is abnormal, that's all. There is no stricture. The duct is abnormal but no stricture. Abnormal duct but no stricture. So who will have stricture? Stricture is seen in type 3. So stricture and communication are seen in type 3 DEGDO classification. Stricture and communication are seen in DEGDO 3. Remember that point. So stricture and communication are seen in DEGDO 3 classification. So now, what are the classical clinical features of this patient? This patient presents after 4 weeks of episode of acute pancreatitis. They come to hospital with what symptom? They will have pain, epigastric fullness, and they have vomiting. They may have early satiety. So these are all typical symptoms because of the pseudocyst compressing the stomach. So this patient comes to you at 4 weeks, and when you measure serum amylase, it will be persistently elevated. That will be elevated. In spite of being 4 weeks, the serum amylase is still elevated. It's one of the clue to say there is a pseudocyst. And when you do investigation of choice for pseudocyst, answer is CECT abdomen. You can diagnose pseudocyst. CECT abdomen is diagnosed with a simple investigation, CT abdomen. And if you do fluid analysis, so whenever there is a pseudocyst, we all will have one big doubt whether it is a ordinary pseudocyst or a mucinous or a serous cystic neoplasm. What you should do? You should do fluid analysis. There will be increased fluid amylase value. Please remember, there will be increased fluid amylase value in this fluid. The fluid amylase will be increased, and the CEA will be normal. These are the two important things to say it is pseudocyst. So when you get a pseudocyst, when you aspirate the fluid and see, the fluid amylase will be increased and CEA will be normal. Please don't forget this. CEA will be normal. So now, how are you going to manage a pseudocyst? Usually pseudocyst resolve. Please remember, usually pseudocyst resolve. They may not need surgery. For a pseudocyst which is having pain or compressive symptoms, then only we do surgery. Please remember, when there is a pain or compressive symptom, or there is any associated complications in a pseudocyst, then only we plan for a surgery. Otherwise, most of them will resolve in few weeks. And there is a old rule which is no more there now. We are not following this rule. That is known as rule of 6. If the cyst is present for more than 6 weeks, if it is more than 6 centimeter diameter, and if it is more than 6 millimeter thick wall, the wall thickness more than 6 millimeter, or the cyst is more than 6 centimeter diameter, that cases we operate. That's a old rule. Now it is not so. So now we operate based on the symptoms. Based on the symptoms and complications, we operate. So what are the complications you should know in pseudocyst? Can you tell me what are the complications? The most common complication of pseudocyst is it can rupture. Sorry, it can cause infection. Infection is the most common complication of pseudocyst. The most common complication of pseudocyst is infection. If it gets infected, it becomes pancreatic abscess. The most common complication is infection. So then rupture. Other complications are rupture. It can rupture into the abdominal cavity and cause pancreatic ascites, or it can cause peritonitis features. If it is an infected rupture, it can cause peritonitis features, or it can cause pancreatic ascites. If it ruptures into the thoracic, it is causing pleural effusion, which is also known as pancreatico-pleural effusion. And the pleural effusion fluid will have more amount of amylase. And there is another important complication. Please don't forget, they can go for bleeding. Bleeding is another dangerous complication. All these are various complications. Therefore, we should plan for a internal drainage is the treatment of choice for uncomplicated pseudocyst. So please remember, internal drainage is the treatment of choice. Internal drainage means we have to drain the cyst. For example, if this is a cyst with a fluid, we have to drain it because many times there will be communication. Many times there will be communication present with the pancreatic duct. So please remember, we should not do external drainage because many times there will be communication with the pancreatic duct. If you do internal drainage, it will resolve nicely. So internal drainage is the treatment of choice. Internal drainage is the treatment of choice. It can be done by endoscopy. Please remember, it can be done by endoscopy. It can be done by laparoscopy. It can be done by open surgery. So there are many methods of doing internal drainage. Internal drainage can be by endoscopy, laparoscopy, or open method. That is known as cystogastrostomy. If the cyst is very close to the stomach, drain it to the stomach, cystogastrostomy. If it is near duodenum, drain it to the duodenum, cystoduodenostomy. If it is not close to stomach or duodenum, take a rule limb of jejunum and anastomose with a cystojejunostomy. So any one of these is possible. Whichever is ideal, you should do. Anyhow, the internal drainage is best. If it is very close to stomach, drain it to stomach. If it is close to duodenum, drain it to duodenum. If it is not close to stomach and duodenum, take a rule limb of jejunum and anastomose with the cyst. So that is the treatment, cystogastrostomy. Endoscopically it can be done. Endoscopic cystogastrostomy, endoscopic cystojejunostomy, endoscopic cystoduodenostomy, or by laparoscopy also you can do all these things. But if there is an infection, of pseudocyst, no other way, we have to drain it externally. Please remember, infection is present, that should be drained externally. So infected pseudocyst, external drainage advised. So please remember, infected pseudocyst, external drainage is advised for those patients. Okay. So these are the points you should not forget in pseudocyst. Now let me discuss about pancreatic ascites. It is a super specialty level topic from Sabiston, pancreatic ascites. Pancreatic ascites patients, the major problem is there is a communication with the pancreatic duct. So please remember, there is a communication present. That is the main reason for pancreatic ascites. From the pancreatic duct is disrupted and leaking the fluid into the peritoneal cavity, and the patient comes to you with abdominal distension. And analysis of the fluid shows increased amylase level. And it is a low protein ascites or high protein ascites. It is a medicine question. It is high protein ascites. So please don't forget, it is high protein ascites. In otherwise, you will be reading in medicine, it is a low SAG, serum ascites albumin gradient. It is low SAG ascites. So there is increased amylase and high protein ascites is present. Please don't forget, there is increased amylase and high protein ascites. So this ascites patients have communication present. So what is the treatment protocol? The initial treatment protocol is we will do paracentesis. Initially drain the fluid, paracentesis, along with give some injection octreotide. Do paracentesis and give injection octreotide. If it is not resolving, then you plan for endoscopic therapy. Endoscopically, you try to put a stent by ERCP and pancreatic stenting is done. Because there is a duct disruption, you can pass a stent against that disruption. If there is a duct disruption like this, see, there is a duct disruption like this, endoscopically what we can do, we can put a stent inside like this, so that the fluid will not leak out. So this is the second option. So finally, when will you call a surgeon? Finally the surgeon is called only when there is a failed ERCP stenting. After putting a stent also, there is an ascites, then only a surgeon is called upon. We go and open the duct and we do lateral pancreaticojejunostomy, LPJ, that is nothing but Pusto operation will be done. So we open out the duct fully and we do a pancreaticojejunostomy known as lateral pancreaticojejunostomy operation of Pusto will be done. Please don't forget, of Pusto will be done. So lateral pancreaticojejunostomy of Pusto will be done for those patients. So these are the points you should not forget in pancreatic ascites. This question is a JIGMAL question asked last year. What is the indication of surgery? So indication of surgery is only when there is failed ERCP stenting, then only we plan surgery. Otherwise we don't do surgery. So first is paracentesis, then ERCP stenting, then only comes LPJ for pancreatic ascites. So the two important complications for surgery are pancreatic ascites and pseudocyst. And the next complication, very important for AIMS level exams, is pancreatic necrosis. High yield topic for your exams. Pancreatic necrosis. What do you mean by necrosis? In CT severity index, I told you 2 point is given when there is less than 30% necrosis. How many points will I give for 30 to 50% necrosis? 4 point is given. 6 point is given if there is more than 50% necrosis. What is this necrosis? When you do a contrast CT, the pancreas should look white. If instead of looking the pancreas looking white, if there are some black patchy areas like this, they are all known as necrosis. Please remember, the pancreatic necrosis is usually sterile. It is usually a sterile necrosis. It is not infective necrosis. So it is usually a sterile necrosis. We have to wait. Many times the sterile necrosis will heal it by itself. Or sometimes it can be infective necrosis also. The infective necrosis is identified by the presence of air, elevated WBC count, patient remaining toxic, presence of air, patient is toxic, WBC count is very high. So there are some other markers which are not essential for PG level to know there is an infective necrosis. Okay, we will measure trypsinogen level, all those things we will measure, and if there is an infective pancreatic necrosis, definitely this is the place where we start the antibiotic. Antibiotics are not started for all acute pancreatitis. It is started only when there is a evidence of infection. When there is an evidence of infection, we start antibiotics. Under antibiotic coverage, now you have to remove the necrosis. So remove the necrosis now under antibiotic coverage. That is given a name known as step-up approach. There are two approaches, step-up approach and step-down approach. Step-up approach, first of all, let us understand what is step-up approach. So the patient is already sick. If I go and do a laparotomy, open and remove the necrosis, patient will die. So what I will do in step-up approach is, initially I will do ultrasound guided drainage of the necrotic fluid collection. Ultrasound guided, I will put a percutaneous drainage. If the patient is recovering, let me wait for some time. After he recovers, then I will go, for example, if this is a patient having a necrosis. So there is a necrosis here in the pancreas. Now I have asked the radiologist to put a stent like this. They have put a stent and that is draining the infective fluid. So the patient will slowly improve. At that time, now I will introduce minimally invasive method. What is minimally invasive method? Can you tell me? It is either by laparoscopy. I will not do laparotomy. Please remember, I will do a laparoscopic. I will do laparoscopically minimally invasive laparoscopic necrosectomy will be done. I will remove that by laparoscopic necrosectomy. Or else there is a question for neat super specialty people, that is known as through this tract I will introduce a nephroscope. I will introduce a nephroscope through that tract. Through that tract I will introduce a nephroscope, and through that I will remove the necrosis outside. That is known as video assisted retroperitoneal debridement, known as VARD procedure. Video assisted retroperitoneal debridement procedure. Video assisted retroperitoneal debridement procedure. Please don't forget, for pancreatic necrosis, the procedure we do is VARD, video assisted retroperitoneal debridement, high yield MCQ topic. VAR procedure, video assisted retroperitoneal debridement, is through the PCD port, through the same place which we put the PCD. We go inside and remove the necrosis and come out. So this is known as step up approach. This is what we commonly follow. So step up approach is what we commonly follow. We go from slow procedures. Like initially we go ultrasound guided, then we go minimally invasive. If it is further having problem, then only we go for open laparotomy and lavage. That is the last. So open laparotomy and lavage will be done as a last. So this in open laparotomy and lavage, we keep a drain inside, and 2 drains will be kept. 1 drain will be washing, and there will be closed continuous drainage will be made. So that all is not important for you. But remember, this is what we commonly do: step up approach in management of pancreatic necrosis. So the 3 complications we discussed are pseudocyst, pancreatic ascites, pancreatic necrosis. Pseudocyst, DEGDO classification, don't forget. Treatment of choices, internal drainage, don't forget. Pancreatic ascites, there is a communication seen with the duct in about 80% cases. So initially we try with the paracentesis and opiotype. Second line stenting, third line only we do surgery. Necrosis, please don't forget, we have to go with step up approach. And in step up approach, don't forget, there is a procedure known as ward procedure. Don't forget, there is a procedure known as ward procedure. So now let us see the images of what we have discussed. So this is a classical picture showing you an annular pancreas. You can see the typical annular pancreas compressing the second part of duodenum. Please don't forget, it is associated with Down syndrome. Okay, Down syndrome, annular pancreas. Treatment of choice from variant law is duodenostomy. And this is a classical picture showing you pancreas divisum. You can see the minor duct is draining the entire pancreas, and main duct is only draining small part of the head. So the main duct is also draining the bile duct. So therefore, this is going to have recurrent acute pancreatitis. We have to do sphincterotomy of this place. We have to do minor duct sphincterotomy over here. So please don't forget, we have to do minor duct sphincterotomy over here. So high yield MCQ image based question. This is known as what sign? Cullen sign. This is Gray Turner sign, and one more sign here is Fox sign. Okay. And this is a picture showing you a typical colon cutoff sign. High yield MCQ again. Colon cutoff sign. So typical picture of colon cutoff sign is shown here. And you can see here in this picture, this is a normal pancreas. Please don't forget the anatomy of normal pancreas. So this is aorta, this is IVC, and this is SMA. Okay. Please don't forget the normal anatomy of pancreas. Okay. So this is a typical normal anatomy of pancreas. So the various scoring systems I told you, please don't forget those scoring systems. BISAC scoring system, bedside index of severe acute pancreatitis, B for blood urea nitrogen, I for impaired mental status, S for SIRS, age above 60, P for pleural effusion. Can be performed in 24 hours. So Hansen scoring, don't forget the mnemonic, Lagau, Buchau, LDH, aspartate transaminase, glucose, age, WBC count, and Buchau base deficit, urea nitrogen, calcium, hematocrit fall, PaO2, water fluid loss. If it is more than 3, it is known as severe acute pancreatitis. So there is an Apache scoring system with the 12 factors. If you are possible to remember, you can remember. It is there in your material, but I am very difficult to, I never read this because not asked in exams also, even for super specialty not asked, but this is just 12 factors which are included in Apache 2. And CT severity index, I told you, if the scoring is 7 to 10, they have 17% mortality. So very severe acute pancreatitis. Okay. So presence of single fluid collection is 3 point, 2 or more fluid collection is 4 point, peripancreatic changes is 2 point, only enlargement is 1 point. So less than 30% necrosis is 2, 30 to 54, more than 50 is 6. So this is Atlanta classification as I discussed. Please don't forget the Atlanta classification. Mild is no organ failure, no local complication. Moderate is there is organ failure, transient. Severe is persistent. After 48 hours also they have organ failure. So classical image, this question definitely you get this image. This is a classical pseudocyst. So pseudocyst in the head of pancreas. You can see this is a pseudocyst following a chronic pancreatitis. So this is a pseudocyst following a chronic pancreatitis. So this is known as DEGDO classification number what? Type 3. Okay. And this is DEGDO classification following an acute pancreatitis. This is type 1. All these are my patients. So type 1. So please don't forget these points in acute pancreatitis. Most pseudocyst, most common site is lesser sac. Presence after 4 weeks of acute pancreatic fluid collection. Most common complication is infection. Best treatment is internal drainage into the GIT. So this is the DIGDO classification I told you. So please don't forget only 3 is chronic pancreatitis having abnormal duct stricture communication. Abnormal duct stricture communication is known as DGO. So this is a picture showing you a cystogastrostomy being done by me. A cyst is being compressing, the anterior wall is opened, and through the posterior wall I am going to drain the cyst into the stomach. So this is a surgical cystogastrostomy. This can be done by laparoscopy or by endoscopy also. So this is one of my patients showing you an abscess. One of the patients you can see here. I'm going to open the cyst. The moment I'm opening the cyst, you can see in this image, there is full of pus going to come out. So this is a pancreatic abscess, an infected pseudocyst, full of pus coming out in this. So classical pus. So what I will do, I will not do a cystogastrostomy. I will do it, drain it externally. Okay, I will drain it externally. So this is a picture showing you a pancreas here. And what are these arrow marks showing you? The pancreas is black in these places. This is normal pancreas. Here it is black. So this is a complication known as pancreatic necrosis. Pancreatic necrosis. Okay. So this is a picture showing you video assisted retroperitoneal debridement. You can see the previously put PCD, percutaneous drainage tube is inside that. Through that PCD tract only we do ward. Ward is done through the PCD tract. Remember that. Ward is done through the PCD tract. Okay. Done through the PCD tract. So now let us go to the chronic pancreatitis. Now we go to the next topic, that is chronic pancreatitis. So we have finished acute pancreatitis. I told you acute pancreatitis is like a cobra snake. At any time it can kill the patient or it can kill you. So before we go into chronic pancreatitis, let me give you a brief outline of management of acute pancreatitis. So any discussion is not over without discussing the management. So let us discuss the management of acute pancreatitis. So I'm going to divide the management into 2 headings. Under 2 headings, they are mild acute pancreatitis, how I will manage, severe acute pancreatitis, how I will manage. So definitely there is a difference in management for both cases. Both are not managed by same way. So anyhow, the key in the management of these 2 cases is fluid replacement. The key in the management of both cases is fluid replacement. You have to give good amount of fluid. That is the key. IV fluid is the key, such that the urine output should be very well. So good amount of fluid with a good urine output is the key in the management of acute pancreatitis, whether it is a mild or severe. So mild acute pancreatitis and severe acute pancreatitis, where do you treat them? Treatment will be done. Mild acute pancreatitis you can treat in your general hospital. You can treat as an hospital patient, hospital inpatient, just like a normal patient you can treat. But severe patients need surgical intensive care unit management. So please remember, surgical intensive care unit. That's the first point. I'm going to discuss 5 points. So treatment of mild is you can manage in your hospital, just like a regular patient ward. But severe cases need SICU, and severe cases need multidisciplinary setup. Multidisciplinary team is needed. So multi-specialty hospital should be there. And number 2, in the management of mild and severe cases, antibiotics will you give or not? Is there a role of antibiotics in acute pancreatitis? Definitely no role in mild cases. Definitely no role in mild cases. But severe cases, especially when it is an infective necrosis, we can give. Even in severe cases, only when there is an infective necrosis, we give antibiotics. Okay. Analgesics. Yes, analgesics definitely have a role in both cases. What type of analgesic is not advised? So we give them only opioid analgesics. Please remember, opioid analgesics is better advice. Don't give non-steroidal analgesics because they are already in stress, and non-steroidal analgesics can cause bleeding. So the opioid analgesics, the commonly used drug is tramadol. You all know very well. Tramadol is used for pain. The commonly used analgesic is tramadol. So metamizole, tramadol are all used. And about giving nutrition, the fourth point about giving the nutrition, which we have already discussed in the first chapter itself about nutrition in acute pancreatitis. So nutrition in acute pancreatitis. Please don't forget, nutrition can be normal feeding, can be advised for mild cases because it's only mild pancreatitis. So they can take normal feeding, nothing will happen. Normal feeding. If by chance they are not tolerating normal feeding, we go for nasogastric feeding. So we go for nasogastric feeding. If nasogastric feeding is also not tolerated, then we go for nasojejunal feeding. So please remember, nasogastric feeding nutrition is advised for mild cases. So mild cases of acute pancreatitis, if they are unable to have their food by themselves, the feeding method of choice is nasogastric feeding, and this is a direct line from VLO. So the feeding method for mild pancreatitis is nasogastric feeding. So nasojejunal feeding is advised if there is vomiting and the patient is unable to tolerate nasogastric feeding due to duodenal edema or compression. Otherwise, NG feeding is enough. And coming to severe pancreatitis, patient is in shock. If a patient is in shock, definitely we should not give enteral nutrition. If patient is in shock, we should give total parenteral nutrition. That is advice for patient who is in shock. We advise total parenteral nutrition. Surgical intervention, will you do any surgical intervention? If you do any in these patients, surgical or any intervention, not only surgical, any other intervention. So for gallstone pancreatitis, the only thing what we can do for surgical intervention is for gallstone pancreatitis. Please remember, many times the gallstone pancreatitis, the point you should note here is, there should be typical case of gallstone pancreatitis. We can advise them ERCP in less than 72 hours can be advised. So ERCP can be done within 72 hours in selected cases of gallstone pancreatitis associated with cholangitis. A patient having gallstone pancreatitis associated with cholangitis, we can do ERCP and stenting. ERCP, sphincterotomy and stenting can be done within 72 hours. And most of the time, the mild cases, no intervention done. Most of the time, the mild cases, no intervention done. Only for severe cases, we do various management, especially for pseudocyst, we do cystogastrostomy, necrosis, we do necrosectomy, or for ascites, we do stenting. All those things. For severe cases, intervention is done. For mild cases, usually no intervention needed. No intervention needed. And these are all things which will have doubtful role. Is octreotide has a doubtful role. We don't know whether it is giving good response or not, but octreotide can be advised, but it is not having a 100% good role, but it is having a doubtful role. Octreotide is advised, can be given in case of pancreatitis. So these are the points you should not forget in the management of acute pancreatitis. So what is the nutrition advice? Is nasogastric feeding for mild pancreatitis, and please don't forget antibiotics are not needed in mild cases, it will be needed only for infective necrosis cases. High yield points for your exams. Okay, so these are the points I want you to remember from acute pancreatitis. As I told you, acute pancreatitis, in spite of extreme management, severe pancreatitis patients have around 10 to 20% mortality, and we don't know who will die, who will recover. So it is very risky case to manage. So you should manage them in high multi-institutional setup. Okay. So now I'm coming to chronic pancreatitis. So chronic pancreatitis, as the name says, it is a dead snake. You can beat it as much you want. Nothing will happen. Okay. I used to tell my classes always, acute pancreatitis is like a living cobra snake, and chronic pancreatitis is like a dead snake. You can beat it with the stick as much you want. So you try to manage these cases and admit these patients and enjoy with these patients. Nothing will happen to the patient. They won't die. That is the point you should remember in chronic pancreatitis. So chronic pancreatitis, the major problem is what? Due to recurrent attacks of pancreas or some other issue, the pancreas is now dead. There is no exocrine production. There is no exocrine production. There is no endocrine production. Both endocrine function is lost, exocrine function is lost. And the only reason for the pain is they develop strictures and stones inside. Because of recurrent attack, they develop strictures and stones inside the duct. So remember these three reasons. These are three reasons for getting a patient with chronic pancreatitis. No endocrine function. More than 90% of the endocrine function is lost. Patient develops what symptom? What disease? They develop diabetes. More than 90% of exocrine function, pancreatic function is lost. What symptom the patient develops? Steatoria. The patient develops strictures and stones in the duct. So what they will have? They will have strictures and stones in the duct. So they will have dilated duct and obstruction. So therefore they have pain. So chronic pancreatitis is a triad of pain, steatoria, diabetes. Please don't forget this point. The first point in chronic pancreatitis is they have diabetes, steatoria, pain. Why should they come to a surgeon like you? They will come to you only for pain. So they come to you for pain. So the pain is typical epigastric pain radiating to the back. And here it is not due to enzyme stimulation. It is due to typical obstruction. There is a obstruction. There is a sentinel event happening that will stimulate acute pancreatitis, and that keeps on going, and finally it lands up in chronic pancreatitis. And the pain here is not due to enzymes, So the pain here is not due to enzymes, it is due to obstruction and ductal hypertension. The main reason for pain here is ductal hypertension is the cause of pain here in chronic pancreatitis. So there are so many classifications of chronic pancreatitis, and the classification I want you to remember for your exam for chronic pancreatitis is Tiger O classification of etiological factors. So Tiger O classification, it is a mnemonic by itself. So Tiger O is a mnemonic by itself. So the most common cause of chronic pancreatitis is toxic, which is nothing but alcohol. So most common cause of chronic pancreatitis is toxic, which is alcohol, is the most common cause of chronic pancreatitis. 2 is idiopathic. Idiopathic, unknown cause, or it can be also said as tropical. Tropical chronic pancreatitis is especially seen in Kerala due to eating of cassava root fibers. They are very common among people eating cassava root fibers in Kerala. It is one of the cause of tropical chronic pancreatitis. And genetic. Can you tell me some genetic mutations causing chronic pancreatitis? Genetic mutations are PRSS gene mutation. PRSS gene, it is nothing but trypsinogen gene. SPINK1 gene mutation. PRSS gene mutation. Cystic fibrosis transmembrane gene mutation. So these are some mutations: cystic fibrosis transmembrane, SPINK1, trypsinogen, PRSS gene. All these can cause genetic causes of chronic pancreatitis. And A for autoimmune. Or for recurrent, can you tell me where I told they will have recurrent acute pancreatitis? Which condition I told you? Patients may have recurrent acute pancreatitis. They are like pancreas divisum is one case where the patients may have recurrent acute pancreatitis. And another is obstructive. Obstructive is maybe due to stones or stitches. Obstructive due to stones or stitches. So this is known as Tiger O classification. Toxic, idiopathic or tropical. And please don't forget genetic causes may be asked in exam. PRSS gene, SPINK gene, CFTR gene, cystic fibrosis transmembrane receptor gene. So PRSS gene, SPINK1, cystic fibrosis transmembrane gene. All these are genetic mutations. Autoimmune, recurrent acute pancreatitis, and obstructive are the various causes of chronic pancreatitis. So the clinical feature of this patient presents to you like a bone and skin. The patient will be like looking like a bone and skin because he was having steatoria, diabetes. So he would have lost his entire weight. So he will look like a retroviral disease patient. He will be bone and skin. The main reason he will come to you will be pain. This is what he will come to you. And many times these patients you would have seen in your ward, they would have been managed only by analgesics. Many times they are addiction of opioid analgesics. Many times the patient themselves will come and tell, please put me Tronal, please put me 14, like that. The name itself will be known for those patients. The typical addiction will be there. So pain, diabetes mellitus, which will respond only to insulin, will not respond to over hypoglycemic agents. The sugar will be more than 300, respond only to insulin, and they will have steatoria. Patient will tell, sir, my motion is floating on the basin. It is not sinking, it is floating motion. That is typical steatoria. All these are classical features. And when this patient comes to you, we can test out whether there is really steatoria or not by doing certain investigations recently. The old tests which are not done nowadays. Can you tell me only the names that may be asked for chronic pancreatitis? Olden days test are Lund-Meal test, pancreolaureil test. All these are tests which will put a tube inside and take the pancreatic enzyme for testing. That is no more done. So what is done now for looking for pancreatic enzyme deficiency is by fecal measurement of elastase. Please remember, we can easily measure fecal elastase value. So fecal elastase value less than 100 means there is severe chronic pancreatitis or severe exocrine deficiency. When it is less than 100, there is severe exocrine deficiency. When it is more than 200, it is normal. So less than 200 is severe chronic pancreatitis. Or else we can measure fecal fat excretion, fecal fat estimation. So fecal fat estimation, give the patient 100 gram of fat to eat, ask them to take 100 gram of fat per day, and you measure the fecal value next day. When the fecal value is more than 7 grams per day, no doubt it is steatoria. Of the 100 gram of fat eaten, more than 7 grams coming in the stools is fecal fat positive. So these are tests to do tests for steatoria. So what is the latest method of confirming steatoria is by these two tests. So steatoria is nowadays confirmed by fecal elastase level or fecal fat estimation level. Fecal elastase level or the fecal fat estimation, we can confirm the steatoria. We can confirm the steatoria by doing these tests. But anyhow, what is the investigation of choice to diagnose established? Please remember this point. Established are not mentioned as established, and only the question is chronic pancreatitis. Answer is what? So established or chronic pancreatitis diagnosis, as usual, it's a retroperitoneal organ. Answer is CECT abdomen. That is the investigation of choice to diagnose established or a long-term case of chronic pancreatitis, which will show you stricture in the duct, stone in the duct, atrophy of the pancreas. All those things can be diagnosed on a CT scan. And what is the gold standard now? Gold standard to diagnose yearly changes. Please remember, gold standard to diagnose yearly cases of chronic pancreatitis. Yearly cases of chronic pancreatitis. What is the gold standard to diagnose? Answer is what? Old answer, new answer. What is the old gold standard to diagnose yearly changes of chronic pancreatitis means? Answer is ERCP. New gold standard is EUS. So old gold standard ERCP will show you the duct abnormalities, duct dilation, etc. And all of you know very well one old MCQ known as chain of legs appearance. SCN, ERCP of chronic pancreatitis. ERCP of chronic pancreatitis shows you chain of legs appearance in a ERCP in chronic pancreatitis. And there is a criteria to say the chronic pancreatitis. The criteria is known as what? High yield MCQ for exam, national board favorite question. That is, please don't forget, that is Cambridge criteria. Okay, Cambridge criteria is a criteria to diagnose ERCP of chronic pancreatitis. The criteria is known as Cambridge criteria. And recently there is endoscopic ultrasound which can focus exactly on the pancreas through the stomach wall. We can keep the ultrasound probe on the stomach wall through inside onto the pancreas, and we can scan the pancreas. And that is having a criteria name known as Rosemont criteria. Rosemont criteria. These two questions are very important in this topic. So though I am not explaining about the criteria, they may not be asking the explanation of the criteria, but definitely they will ask you the names. Cambridge criteria is ERCP criteria of yearly chronic pancreatitis. Rosemont criteria is EUS of yearly chronic pancreatitis. Please don't forget these 2 points. High yield MCQ topic for you. Okay, please don't forget Cambridge criteria, Rosemont criteria, both these things. You should not forget Cambridge and Rosemont criteria. So the investigation of choice for an established or diagnosis of chronic pancreatitis is still CT abdomen. Only for yearly cases, please remember to diagnose it yearly cases of chronic pancreatitis, we use ERCP and EUS. Okay, so please don't forget these points. So don't forget how to diagnose steatoria. And coming to the management of these patients. So the management of these patients is initially by medical treatment only. We manage them medically by giving them analgesics, step-up approach of analgesics. You all know what is step-up approach of analgesics from pharmacology. That is a pain ladder. Step up, we have to give paracetamol first, then Brufen, then Tramadol, like that it goes on. That is analgesics is the first step. Okay, the first step is analgesics. And if the patient is having severe pain, the last step of the analgesic pain management, the last step is celiac plexus block. Please don't forget, celiac plexus block is one step of pain management, because the pain is carried by the celiac plexus. We can either do by laparoscopy, the celiac plexus block can be done by laparoscopy or by radiological intervention. So by radiological or by laparoscopy, we have to put one injection in the celiac plexus that will damage the celiac nerves. What is that injection? So the nerve used to damage the celiac plexus. The drug used to damage the celiac plexus is absolute alcohol, is used to as a neurolytic. So the patient whose pain started because of alcohol is now ending because of alcohol. Okay, his pain is started with alcohol, now stops with alcohol. So absolute alcohol is used for celiac plexus block. So other methods of procedure apart from celiac plexus block are thoracoscopic splanchectomy. We can also do thoracoscopic splanchectomy also can be done. So all these are painkiller procedures, minimally invasive painkiller procedures. So we will step up, and finally for pain because blockade or thoracoscopic splanchectomy can be done as painkiller procedures. And for steatoria, we give them for management of steatoria and weight loss, we can give them pancreatic enzyme supplements. So pancreatic enzyme supplements, what are they? There are many drugs. We will give amylase will be added to the drug. So like some company names are Prion, pancrealipase, all those things are pancreatic enzyme supplements. The only question which can be asked in pancreatic enzyme supplements is when to give this drug, before food or after food or with food. So pancreatic enzyme supplements should always be given along with the food. So please remember, it should be given along with food. So eating in between the food itself, they should eat the pancreatic enzyme capsules. And very important point in pancreatic capsule supplementation is when you consume pancreatic enzyme supplement, we should always add what? We should always add PPI, because acid environment can destroy the pancreatic enzyme supplement. So two important things you should know while giving pancreatic enzyme supplement is you should give PPI along with the, before taking food, we should give PPI to reduce the acid so that the pancreatic enzyme tablet will go and act on the duodenum. So it should be given along with the food. And for diabetes, we should give them injection. Insulin is given for diabetes. So these are the medical managements of chronic pancreatitis. So they will be on these medical management. Now coming to the surgical points in chronic pancreatitis. Surgical management of chronic pancreatitis. So surgical management is not much important for PG level, but let me give you a brief outline. So if the duct is, the following are the methods of surgical management. One is drainage procedure. Please remember the procedures can be divided as drainage procedure. Two is resection procedure. And another one is hybrid procedure, which is combining both. So drainage procedure, hybrid procedure, and resection procedure. So drainage procedure. For a patient who comes to you with a pancreatic duct, dilated, with stones. So if the pancreatic duct is dilated with stones like this as shown in this image, what will you do? What drainage will you do? So the latest method of draining this pancreas is known as modified Pustow operation. Modified Pustow operation. So please understand there is nothing to look up. What is modified Pustow operation? For a dilated duct. So please remember, for a dilated duct, all over the pancreas, I dilated duct with stones. I will lay open the duct. Please remember, I will lay open the duct and I will bring a jejunum and anastomose. That is known as lateral pancreatico-jejunotomy. So I will bring a jejunum and anastomose like this. So this is known as modified Pustow operation. So dilated duct drainage procedure is modified Pustow operation. So nothing to look up, just know the names. If the duct is not dilated, undilated duct. The duct is undilated, but there are some strictures and some stones. The duct is very small, not dilated, and some strictures are there. We make V-shaped cut. We make a V-shaped cut along the duct like this. We shape a V-shaped cut. V-shaped cut is made on the duct. That is known as Isbecki operation, Isbecki procedure. So Isbecki procedure is done for undilated duct. Same way, after opening, we put a lateral pancreatico-jejunotomy. Isbecki procedure is done for undilated duct. So for dilated duct, we do modified Pustow, lateral pancreatico-jejunotomy, and for undilated duct, we do Isbecki procedure. Okay, so this is only drainage. We don't remove any pancreatic substance. Hybrid means resection as well as drainage. Please remember, if there is a pancreatic head mass, the mass in the head, along with the dilated duct and stones. Please remember, the duct is dilated with stones. There is a mass in the head also. What I will do? Now what I will do is, I will core this head out. And lay open the duct. So head coring will be done by me. Please remember, the entire head area will be cored out. Head coring will be done along with lateral pancreatico-jejunotomy. Now I will bring a jejunum and anastomose like this. After coring the head out, I will bring a jejunum and anastomose. What is the name of this procedure? Head coring lateral pancreatico-jejunotomy is known as phrase procedure. Highly expected MCQ5. So among all these procedures, this is more important for your exam. That is known as phrase procedure. So please don't forget, drainage procedures for dilated duct is modified Pustow, undilated duct is Isbecki. And a hybrid procedure is head coring with lateral pancreatico-jejunotomy known as phrase procedure. And resection procedure, please come to the resection procedure. If there is a problem only in the tail like this, if there is a problem only in the tail like this, what we do is, we do a procedure known as distal pancreatectomy with splenectomy. If there is a problem only in the tail, we remove the distal tail and the spleen. That procedure is known as child dual procedure. Distal pancreatectomy with the splenectomy is done. If the problem is there in the tail, remove the tail and throw it out. Child dual procedure. If the problem is there only in the head, like this, body and tail are normal. What I will do is, please understand this, what I will tell you here. I will remove only the head. Preserving the duodenum. Usually it is very difficult operation to preserve only the head. I will remove only the head, preserving the duodenum, and do an anastomosis like this with the jejunum. So this procedure of removing only head, preserving duodenum is known as duodenum preserving pancreatic head resection of Beager operation, also known as Beager's procedure. So duodenum preserving pancreatic head resection is known as Beager's procedure. So there are so many other procedures for chronic pancreatitis. Just know these names. Only drainage procedure is modified Pustow and Isbecki. Hybrid procedure is phrase. And please don't forget that two resection procedures are child dual, which is nothing but distal pancreatectomy plus splenectomy. DPPHR, which is removing only the head. Only this head is removed. And we bring a jejunum and anastomose there, known as duodenum preserving pancreatic head resection of Beager operation of Beager. So this is known as Beager's procedure. So we can also do Whipple's. Sometimes we also advise Whipple's procedure in resection, but nowadays not done. Just for completion, I'm telling Whipple's is a olden days procedure for chronic pancreatitis. Now it is done only for malignancy. So remember, for exam, the name of the procedure is done. So for your exam, I expect you to remember, for exam, the names alone. That's enough. So for your exams, remember the names. Let me show you the PowerPoints now. So what is the most common cause of chronic pancreatitis? Means alcohol is the most common cause of chronic pancreatitis. So pancreatitis, tropical pancreatitis, hyperparathyroidism, trauma, idiopathic cystic fibrosis, heredity, or various other causes. So Tiger-O classification, please don't forget, and don't forget the mutations, PRSS, SPINK, and CFTR. So this is a picture showing you an X-ray showing you multiple stones in the pancreas. X-ray. So the values, please don't forget, value of less than 100 fecal elastase is severe pancreatic insufficiency. More than 7 gram per day is steatoria. So Rosemont criteria is for EUS, Cambridge for ERCP. Please don't forget Rosemont, Cambridge. So this is a picture showing you a chronic pancreatitis, such a huge stone. This is one of my patients showing you such a big stone. So I'm identifying the duct, removing the stones. You can see I have removed all the stones from the duct. I have cored out the pancreas and I have removed all the stones. So this is one of my phrase procedure done some years back. And this is a completed picture. You can see the head cored. This is the procedure we commonly do surgical gastroenterologist. This gives better pain relief. So I used to do this. So you can see the head is cored and duct is lay opened, and I will now do a phrase procedure. Please don't forget phrase procedure. Okay. So this is a ERCP showing you normal pancreatic duct. You can see the normal pancreatic duct. So this is a ERCP showing you dilated duct. You can see in this picture dilated duct. And this is what we say as chain of legs, like a chain of legs. The stones and strictures will form a chain of legs appearance in chronic pancreatitis. Okay. That completes the acute and chronic pancreatitis. These are the benign topics in pancreas you must be thorough. So please don't forget acute and chronic pancreatitis. Okay.